Hello, BTK listeners. My name is Patrick Georgoff, and I'm a trauma surgery fellow at the University of Texas in Houston. And today we're going to work through an ARDS algorithm that I put together for use at Memorial Hermann Hospital. Now, before we get started, I want to thank some folks at the University of Michigan, specifically Lena Napolitano, Pauline Park, Krishnan Raghavendran, and other experts who trained me how to use a ventilator and whose institutional algorithm, which was developed by the working group, the respiratory therapy working group, was used in helping to put this actual version together. Now, it's important to note that this is an algorithm, that it's not a guideline, and that management of ARDS patients remains very much provider and patient specific. Now, with that being said, there is a lot of great high-quality data out there. And as you can see in this algorithm, this algorithm links to it, it summarizes it, and you can even see that we grade the quality of the evidence. Now, for a more introductory or basic review of ventilator modes, please review the talk titled Ventilators Simplified, which is also available on the Behind the Knife YouTube channel. Now, this guideline is not at all COVID-19 specific. COVID-19 is a viral pneumonia that can, in fact, result in ARDS. But most, and if not all, of the treatments summarized here can be applied to COVID-19 patients. So let's go ahead and get started. Now, first of all, what is ARDS? ARDS is an acute, diffuse, inflammatory form of lung injury that results from a very wide variety of etiologies. Now, normally healthy lungs regulate the movement of fluid to maintain a small amount of interstitial fluid and more or less dry alveoli. Now, this is interrupted by lung injury causing excess fluid in both the interstitium and the alveoli. And acute respiratory distress syndrome, or ARDS, is a consequence of an alveolar injury producing diffuse alveolar damage. And the injury causes release of pro-inflammatory cytokines, and these cytokines recruit neutrophils and other bad actors to the lungs where they become activated and release a whole bunch of toxic mediators that can damage the capillary endothelium and the alveolar epithelium. And the consequences of this include impaired gas exchange, decreased compliance, and increased pulmonary arterial pressure. So let's get started here at the beginning of the algorithm. So what is the diagnosis, or how do we diagnose ARDS? And this is according to the Berlin criteria, which were created in 2012. And as you can see here in the algorithm, you have to meet 4 criteria, the first being timing. Okay, the diagnosis has to be made within 1 week of a known clinical insult or new or worsening respiratory symptoms. On chest imaging, there must be bilateral opacities that are not fully explained by effusions, lung collapse, or nodules. We also have to look at trying to rule out the origin of edema and ensure that it's not explained by cardiac failure or by fluid overload. And new to the Berlin 2012 criteria are these specific P to A ratios, or levels of hypoxia, with mild being a P to A ratio of 200 to 300, moderate 100 to 200, and severe less than 100 millimeters of mercury. So when treating a patient with ARDS, we want to start at the very beginning with lung protective ventilation. So this comes from the ARDS network original studies that were performed, first being released in 2000, showing that this low tidal volume and low pressure ventilation strategy is actually beneficial to the patient. Now, again, the original ARDS NET trial was published in 2000 in the New England Journal of Medicine. It's the only ARDS ventilator strategy that has been proven to reduce mortality. So I'm going to repeat that again. Low tidal volumes are the only ARDS ventilator strategy that has been proven to reduce mortality in terms of what you can do on the ventilator in ventilator settings. Now, this original study proved that the use of lower tidal volumes, and these lower tidal volumes resulted in lower plateau pressures, not necessarily higher PEEP, but lower plateau pressures, decreased mortality and increased time off of the vent in patients with ARDS. So when talking about plateau pressures, okay, with a plateau pressure being less than 30 centimeters of water, this really kind of bleeds into this relationship between volume and pressure. Okay, and the prevailing thought is that in contemporary ventilatory management of ARDS patients, there's a type of somewhat Goldilocks zone where you have to have enough PEEP to avoid atelectasis trauma and DRecruitment, but not so much tidal volume that you have volume trauma and over distension. Moving on to PEEP. So PEEP is a bit of a mixed bag. There have been 3 large randomized controlled trials, the LOVE trial, Alveoli, and EXPRESS trials, that showed no improvement in mortality when using higher PEEP settings. There was, however, a meta-analysis based off of these trials that showed improved oxygenation, decreased mortality, and increased time out the vent in moderate to severe ARDS when using individual patient data from each of these 3 larger trials. That meta-analysis is published by Brielle et al. In JAMA 2010. And lastly, let's talk about driving pressure. So this is an interesting concept. This is also relatively new. So the ARDS guidelines are based on low tidal volumes. Excuse me, man. And those low tidal volumes are based on ideal body weight. But this does not take into account lung compliance. Now, compliance is defined by the change in volume over the change in pressure. And when I say it doesn't take into account lung compliance, this is particularly important in ARDS, as ARDS lungs are wet and heavy and inflamed, and sometimes not all of the lung is in fact available for ventilation. So what is the actual mechanical stress on the ventilated portion of the lung? That's a question that driving pressure tries to answer. So driving pressure is equal to the tidal volume divided by compliance, which is also equal in real terms to the plateau pressure minus the total PEEP. And this can be thought of as the real pressure that the lung actually experiences. Now, this was first brought to everyone's attention by Amato and colleagues in a paper published in New England Journal of Medicine in 2015, in which some fancy statistics that are beyond my understanding and patient-level data from quality ARDS randomized control trials was used to determine that driving pressure is most strongly associated with survival, not tidal volumes, not plateau pressure, and not PEEP, but driving pressure. So something to look into in a bit more detail. And again, all of these papers I'm mentioning are linked in this algorithm, and the algorithm is available in the show notes. It's linked in this algorithm and has these little symbols refer to the quality of evidence. All right, so let's talk a little bit about ventilator desynchrony. So why do we care about ventilator desynchrony? Well, ventilator desynchrony is independently associated with worse outcomes. These outcomes include worsening mortality, longer ICU length of stay, and longer ventilatory days. So when someone is desynchronous with the vent, we want to make sure we fix that. And so one of the first things we can do is consider changing the vent mode. Oftentimes, if the patient is spontaneously breathing, one of the most comfortable modes we can put them on is pressure support. So if that's a safe option, that's always a good place to start, switching them over to a fully pressure-supported mode. You can also make minor adjustments to the vents. This could include increasing the rise for pressure-controlled settings or the flow rate for volume-controlled settings. It could also include adding an inspiratory pause or even increasing the tidal volume, although we want to keep that tidal volume less than 8 cc's per kg, ideally 6 cc's per kg of ideal body weight. And I want to show you here in this algorithm, ideal body weight is based on a patient's sex and height. And these two tables on the second page of the algorithm are quick links to ideal body weight. So for example, a male who's 5 foot 10 inches tall, 6 cc's per kg is actually 440 cc's, which may be surprisingly low if you really look at what kind of ventilator settings people are getting in some ICU settings. Okay, so back to ventilator desynchrony. The last thing we want to consider is increasing sedation, and certainly considering paralytics, which we're going to talk about a bit more in a moment here. Okay, so we've defined ARDS. We've talked about lung protective ventilation, low tidal volumes with plateau pressures less than 30 centimeters of water, introduced the idea of driving pressure, talked about ventilator desynchrony and how we can change vent modes, make adjustment in flow rates and patterns, and increasing sedation. But what if the patient continues to fail? And what is failure? This is a somewhat arbitrary collection of numbers, but mostly agreed upon and based in some degree to clinical trials. But a PaO2 of less than 60 and or a SAT of less than 88%, and or a PaO to FiO2 ratio of less than 150 millimeters of mercury. All these are signs that the patient is not doing well. So if in fact they aren't doing well, let's move on to the next pieces of this algorithm. First, prone positioning. So this is another strategy that has been shown in high-quality randomized controlled trials to reduce mortality. I mentioned before the only other strategy, ventilator-specific, that's shown to reduce mortality is low tidal volumes and plateau pressures less than 60. Okay, prone position is the only other thing listed on this algorithm which has been shown to reduce mortality. Now, the original trial that showed reduced mortality was called the PROCEVA trial, published by Guerin et al. In New England Journal of Medicine in 2013. And this randomized controlled trial showed that prolonged proning, greater than 16 hours per day, that was started early, less than 48 hours after diagnosis of ARDS, resulted in a decreased mortality in patients with a P to F ratio of less than 150. There's also a Cochrane review that was published in 2015 that showed, amongst the multiple trials included, that early prolonged proning in moderate to severe ARDS may improve mortality. It's also important to consider what kind of exclusionary criteria there are out there for proning. This could include trauma, maybe traumatic brain injury, pelvic fractures, etc. We also need to think about how this affects the staff. So flipping a ventilated patient over in the prone position requires well-trained staff who are used to doing this procedure and who have the support to not only flip the patient but also monitor that patient in the prone position. Furthermore, you can choose to use something like a rota-prone bed, if you like, almost like a rotisserie kind of thing where the patient can be rotated within the bed. Or you can use normal beds and specific protocols that are used to safely flip the patient, ensure that the ET tube doesn't become dislodged, ensure there's appropriate padding and positioning, among other things. Let's move on to neuromuscular blockade. Neuromuscular blockade with deep sedation. So the initial trial that showed benefit here, and this is a conditional recommendation for use of neuromuscular blockade because we have mixed data. So the initial trial that showed benefit was the Accurasis trial, which was published in New England Journal of Medicine in 2010 by Papazian et al. And it showed that early administration of neuromuscular blockade decreased mortality and ventilator time without causing weakness in ARDS patients with a PDF ratio of less than 150. Last year, however, the PEDAL trial that was published in the New England Journal of Medicine, I should say it's the PEDAL network, and the actual RCT was referred to as the ROSE trial, showed that early administration of neuromuscular blockade did not decrease mortality in ARDS patients with PDF ratio less than 150. So 2 high-quality randomized controlled trials with mixed results. We should note that in the ROSE trial, the use of paralytics also did not seem to harm patients. So if neuromuscular blockade is something that you're considering, you want to initiate it within 48 hours of ARDS diagnosis. You could use medication like rocuronium or cisatracurium, depending on your institutional and pharmacy protocols or preferences. And you want to consider stopping that neuromuscular blockade as soon as you can, depending on improvements on the ventilator. All right, let's move on to avoiding DRecruitment. Okay, and we can do this by increasing mean airway pressure and or PEEP. This refers to the open lung concept. Again, ARDS lungs are inflamed, they're wet, and the compliance stinks. And so the thought is, if you can prop these lungs open, okay, with just the right amount of pressure to improve oxygenation and avoid DRecruitment and collapse of those lungs, that you can improve oxygenation in ARDS patients without injuring or farther injuring that lung tissue. So the first thing we want to hit on here is the PEEP table. So the ARDS network, in all of their studies, use different PEEP tables. So there's a higher PEEP table and a lower PEEP table, as you can see here. The PEEP tables relate to FiO2. So if you're having trouble on the ventilator, you've tried all the initial strategies on the algorithm, we might want to kick this patient up to the higher PEEP table. So for example, FiO2s of 50% could get you to a PEEP as high as 20. Again, this is something much higher than I think most of us are used to, but is in fact part of the ARDS ARDS-NET trial group's management strategies. You can also try recruitment maneuvers. There's a lot of different ways to do recruitment maneuvers, and I would really just rely on your respiratory therapist to let you know what their preference is. But some examples could include switching over to a CPAP setting with 30 to 40 centimeters of water of pressure settings for about 30 seconds, or maybe pressure-controlled ventilation, instory pressure of 40, PEEP of 20 for maybe 2 minutes. But oftentimes these patients are sick and perhaps on the wrong part of the Starling curve. So increasing intrathoracic pressure significantly like this could decrease end diastolic volume and heart filling and decrease cardiac output. So you really need to be at the patient's bedside watching for hemodynamic instability when performing these maneuvers. We can also consider an incremental PEEP trial based on optimal optimized oxygenation, or even using driving pressure. Now, what this refers to is something that has been referred to as a PEEP ladder, or incrementally increasing PEEP until you find the optimal lung compliance. Okay, we won't go into that much greater, but there is within the resources listed here some explanations for how to do a PEEP trial or PEEP ladder. Let's move on to APRV, or airway pressure release ventilation, something that is talked about an awful lot. So APRV is a complicated vent setting that is discussed in some detail in the ventilators simplified video that is also included on the Behind the Knife YouTube page. But within that video, we do include some APRV tips for how you set APRV, including specific numbers for things like the high pressure, low pressure, and time low, and how to set your time low to ensure that you are generating the appropriate amount of auto PEEP and tidal volume. Now, the data behind airway pressure release ventilation is mixed. There are a couple positive studies and an awful lot of studies that show no benefit but not necessarily any harm. So the initial, I got to say, the seminal review of APRV was published by Habashi et al. In Critical Care Medicine in 2005, and this shows how to set up APRV and describe the initial. It really was the initial description of really how to do APRV. In 2017, in intensive care medicine, Zhao et al. Performed a randomized control trial that showed that early APRV increased days free from the ventilator and increased oxygen, all while decreasing the plateau pressure. And finally, Carcetti et al. In the Annals of Intensive Care in 2019 performed a secondary review of 5 randomized control trials that showed a lower mortality and increased days free from the ventilator in ARDS patients treated with APRV. So there's a lot of personal preference related to APRV. I would recommend that you try other non-inverted pressure controlled modes of ventilation first before inverting the patient. You may also find that APRV is more comfortable for patients, as it allows patients to take spontaneous breaths during that inspiratory phase of ventilation. And some patients actually like APRV better, whereas others don't. So certainly worth a try if you're moving down this algorithm and struggling to get results. Next, nitric oxide. So nitric oxide, as you can see, has a very limited evidence to support it. We want to consider nitric only if the above listed strategies do not result in any type of improvement. Now, nitric oxide has been shown to improve oxygenation, but it does not improve mortality, and it does not result in more ventilator-free days. In fact, it is associated with acute kidney injury, and it is very expensive. If we do want to use nitric oxide, we recommend starting at 10 parts per million and increase to 40 parts per million as needed. You can go higher, but it's unclear if you generate any benefit from higher levels. If the FiO2 is stable, we'd recommend decreasing FiO2 by 50%. If FiO2 is stable at less than 50%, we want to wean by 10 parts per million per hour and consider a temporary increase in FiO2 to complete that wean. Now, the reason the specific weaning recommendations are listed here in the algorithm is because it can be hard to get patients off that little last bit of nitric. And sometimes you do have to increase the FiO2 temporarily to get that nitric off before you can come back down on the FiO2. Nitric oxide can also result in methemoglobinemia, and some institutions practice daily or will check daily methemoglobin labs to assess for this. Finally, additional considerations. So the use of conservative fluid management strategies is, in fact, highly recommended. The ARDS network performed a randomized control trial published in the New England Journal of Medicine in 2006 that showed that conservative fluid management strategy increased days free from the ventilator, and that the mean difference in eyes and nose was -7 liters in the group that was managed with conservative fluid management strategies, meaning they got less fluid. Something else to consider is that if the patient has asymmetric lung consolidation, you might want to position the good lung down. You can do this simply by putting a wedge under the patient's back and tilting them in bed. This has the possibility of improving the ventilation to perfusion ratio. And finally, and hopefully we already did this when we were determining our initial diagnosis of ARDS, but we don't want to rule out cardiac dysfunction. Okay. Certainly we don't want to confuse cardiac dysfunction for ARDS or miss concomitant cardiac dysfunction and ARDS. So if we're moving down this algorithm, the patient continues to really struggle, it might be worth circling back and evaluating cardiac function. All right, we've done all these things. We've made, we reviewed all the literature. The patient is still not doing well. What then? Well, the last and final treatment option that we have is ECMO. The one thing I can say is we want to consider an early consult for patients with refractory or severe ARDS, certainly involving the ECMO team at your institution earlier rather than later is a good idea. The surprise ECMO last-minute consult in the middle of the night is definitely something we want to avoid. Now, again, here you'll see that the recommendation, the level of evidence is limited, and we only link to 2 trials here. The first trial was the Caesar trial. Okay, this was a randomized controlled trial published in The Lancet in 2009. This was a seminal paper that showed that the transfer of ARDS patients to an ECMO center improved mortality. However, the study did not necessarily show that ECMO itself is superior to lung protective ventilation. It's important to note also that only 3/4 of patients who were randomized to ECMO actually went on it. More recently was the Eolia trial, a randomized control trial published in the New England Journal of Medicine in 2018. And this showed that in patients with very severe ARDS, there was no statistically significant mortality difference with ECMO. Okay, the ECMO group, the mortality was 35% versus 46% in non-ECMO group. That is not statistically significant. And that there was a significant amount of crossover to ECMO. In fact, about 1/4 of patients crossed over from the control group to the ECMO treatment arm. All right, so that wraps up the algorithm. 2 strategies that were not covered that might be worth looking into include esophageal pressure-guided ventilatory management strategies and the use of high-frequency oscillatory ventilation. So if these strategies are used in your practice, it's probably worth brushing up on them and considering where they fit into your algorithm. And I hope you guys all found that useful. Again, this is a quick review of ARDS management and the data behind it. Again, this treatment algorithm will be posted in the show notes, and I encourage you to download it, review it, and again, to link to these references so that you can better understand the data behind it. Each of these references has a one-liner as well that includes kind of the summary of the study itself. All right. As always, be sure to get out there and dominate the day.